the bottom of Italy, though, is even with New York. So you are all so much farther north than we are.
Mm-hmm. Okay, we are live. Oh, I can see the little icon on the left, which is saying live on Facebook. All right, it's good to know. Okay, we can start.
Okay, well, I'm delighted to have this opportunity to speak to everyone. I do miss not being there in person to be able to see everybody and interact, and particularly I miss all the wonderful food and scenery in Italy, but this is as good as we can do, so I'll have to settle for it. And this is going to be a very fast 60-year excursion through the history of physical therapy and what I hope you people will make the future of physiotherapy. And my reasons for wanting to tell this story is because in some ways, the way physiotherapy began is still an influence on how it's perceived today, even though amazing advances have taken place in the profession. Reasons for the big need for change is because our understanding of the conditions that we typically treat has changed a great deal, as has the role and the background of the physician. And so you put those things together and physios know more about what they deal with and physicians know less about what we particularly deal with. And I hope to make these points clear as I go through this story. And if I don't, then it's up to you all to ask me the questions, and we've allotted time for that. I can kind of say, as I look back when I started as a physiotherapist, that in many ways I was like a medical cheerleader. And in fact, I am so old that I actually started at the end of the polio era.
Yes.
And in some ways, that was a very easy condition to treat because the muscles went away and we knew that they were going to die and that the patients would develop contractures because of the muscles that were no longer opposed. There were some muscles that worked and other muscles that were gone. And so we just needed to strengthen them and to stretch them and to try to help them be mobile again. And of course, as things were supposed to be and did work, the physician diagnosed the condition as polio. Probably most therapists knew it was, but our role was to do the muscle testing to figure out what levels of innervation had been affected by the virus. And the only thing, well, one of the important things that we did then is we did this thing called muscle reeducation. And our big worry was that as some of the muscles were becoming reinnervated one way or another, that we were afraid they would never get a chance to work optimally because other more powerful muscles would overcome these poor weakened muscles. So we call that muscle reeducation. One of the messages from that pertains to this day and time of practice is that there's, even without polio, there is this situation that some muscles get stronger and they overplay counterbalancing activities from their synergists. For example, often the tensor fasciae lata will become a primary hip flexor and the iliopsoas won't do adequate participation because the tensor is doing the hip flexion. The education at the time that physical therapy or physiotherapy first got started were mostly nurses and women that had a degree in physical education. Then they made the educational level for physios in the United States 2 years of college and then 2 years of physiotherapy school. So we got a baccalaureate degree after 4 years at university. And the faculty at Washington University, when I enrolled there, were 3 people were on faculty, none with a PhD, and the science courses, except for anatomy, were all taught by science departments. And just as an indication of how things are changed, there are now at least 40 faculty members in the physical therapy program. There's almost all of them have PhDs, are a clinical doctorate in physical therapy, and there's a practice as well as grant-funded research going on. And there are 80 students in a class instead of 30. At the time, I thought I just had to learn enough not to be dangerous. And most of what I learned was actually from watching physiotherapists after I started to work. So as I go on through the rest of this material, I wanted to clarify some terminology I'll be using because it also helps to clarify the ideas of the physiotherapist's responsibilities versus the physician's responsibilities. So pathophysiology is the pathology associated with a disease, like the polio affected the motor neurons and the brainstem in the spinal cord. Pathoanatomical refers to the specific tissue that was affected, like the motor neurons in the spinal cord and brainstem. And pathoanatomical can also mean a herniated disc or spinal stenosis, the specific anatomical changes taking place in body tissue. Pathokinesiology refers to the movement caused by pathology in a body system. So the polio affected the movement because patients became weak and developed contractures. So the kinesiology refers to the movement that became pathological. And then last, and I think in some ways the most important, is kinesiopathology, which talks about how movement and it becomes impaired and then causes pathology. So conditions like low back pain, I believe even the disc herniation and shoulder pain, are all caused by movements that are no longer optimal and then injure tissues. As our professional responsibilities, physicians are responsible for the pathophysiology and the pathoanatomy, while physiotherapists are responsible for pathokinesiology and kinesiopathology. Okay, and continuing through time, right when I was in physio school, the Salk vaccine came out, and so the polio patients went away. But because we did such a good job with them, we started getting, and they started saving the lives of people with head and spinal cord injured. And of course, stroke patients, they were controlling hypertension, not very well, and cerebral palsy patients. So it switched from lower motor neuron problems to upper motor neuron problems. I know it's hard for you all to appreciate at this point, but it was a very confusing time because all the things we tried to do for the polio patient, we didn't work, and we weren't supposed to do them for the upper motor, for the patients with central nervous system lesions, because now muscles worked, but they didn't work right. So when the physician diagnosed the patient's condition as a stroke or cerebral vascular accident, that helped them, but it didn't help me know how to treat that patient at all. For the musculoskeletal patients, the physician still gave us a very detailed referral of what we were to do, what modalities and what particular exercises. So for the first 5 years, I believe that the physician understood the patient's problem because they made the diagnosis. But for the neurological patient, I still didn't know exactly how to help them regain their function. The belief, like from polio, is that if we could get the muscles to work right, then they would be able to be functional. Now things have changed, so people need to know how the motor control is disorganized so they can plan for how to help them with function and what their prognosis will be. And for the musculoskeletal patient, the belief was that these were all acute problems and that what we could do best would be help relieve symptoms, increase their range of motion, and then strengthen weak muscles because that had to be what the problem was. And but it was becoming clear to me that the physician did not understand at all the disordered motor control of the neurological patient, what we call pathokinesiology. So the highlights were treating this disordered motor control was a big challenge. The treatment was different. And but the good news was I was part of a study where the government came and sent people to watch us work. And because we made decisions, they decided we were professionals and not technicians, which was not clear before this time. And at the time, all the patient problems were considered to be arising from an acute problem. And I'm going to contrast that with today. I think we have good evidence that these things start early and they become chronic, that they go on for a long period of time. I wasn't expecting that I would have to figure out much except determine how weak the muscles were and how much range of motion they had lost. And if I could just make them stronger, improve the range of motion, and cheer the patient on, I would be a success as a practitioner. Okay, so the things that happened then that really weren't so great is that treatment became highly variable because we didn't know what we were treating. And treatment got named after people who popularized what to do, like Bobath, PNF, Rude, and Brunstrom. In the world of musculoskeletal, the manipulative or manual therapy was starting to become a popular technique, most of it arising from Cyriax, who was an MD in England. The big contribution of manual therapy was that physios tried to figure out what was wrong, and it was a joint-related problem that they were trying to figure out. There was an emphasis on the patho-anatomic problem, like what was the structures that were limiting the joint movement. The detriment was treatment became passive rather than using any kind of exercise initially. And it kept the emphasis on the therapy. What do we do to treat people rather than on exactly what was the total underlying condition? And it kept the emphasis on an acute problem. Again, things were named for the developer like Maitland or Kaltenbarn or Stanley Paris. So meanwhile, other questions were arising about the profession, particularly in the United States, like what is our body of knowledge? Do we just provide treatment and we don't know exactly what it should be? And that's when the term pathokinesiology was suggested in about 1975. McKenzie and mechanical diagnosis was becoming popular, and that was a classification system, and that was like one of the first classification systems. And it was a contrast to manual therapy because it encouraged self-treatment rather than just passive treatment. So I became involved in about the 1980s in the idea of classification when Steve Rose came to be head of the physiotherapy program at Washington University. And he wanted to work on classification or diagnosis. And he also wanted to build a curriculum around pathokinesiology. And Steve went on to develop a system that was kind of built on what McKenzie was doing, but he named it for the treatment that was to be given rather than using the terminology that McKenzie was using. Meanwhile, another group of us at Washington University began working on a classification system that was based on movements that seemed to consistently cause pain and that we could observe were not optimal anymore. And then let's just talk a minute about what happened with physician education and practice. When I first started at Washington University, the medical students spent a long time in the anatomy lab. Most conditions were identified by their pathoanatomical location. And then in the 60s and 70s, as they understood the problems differently, the emphasis became on biochemistry and pathophysiology. I know at Washington University now, the medical students spend less than a week on the anatomy of the extremities, and in some medical schools, they don't dissect the limbs at all. It's all looking at where the organs are within the cavities of the body. Meanwhile, what was also developing was the use of radiology to identify both orthopedic and neurological conditions. And there was still with musculoskeletal problems, there was this emphasis on the acute aspect of the pathoanatomical problem, and the treatment by both physical therapists was for physical agents and medications that took care of symptoms by anti-inflammatories or blocking pain. So then things began to change again in my experience because of a physician by the name of John Halasz. And he was the first one to start identifying how lifestyle affects your health. In fact, physical therapy was part of a department of preventive medicine, and they worried about exercise and they worried about diet. It was so far ahead of its time, it went out of existence before people appreciated how far it was ahead of its time. Dr. Halasz actually did what they call translational research now. He would use rats and look at what happens with exercise and changes in diet. And then they also exercised older people. He was the one that discovered the increase in mitochondria with endurance exercises. He clearly demonstrated how exercise can reduce heart disease, diabetes, blood pressure, and that even old people could get better with exercise, which is very reassuring these days for me. So what's clear now is that almost all health conditions begin early and slowly progress over time. And that exercise is like, or activity is like the most effective treatment for preventing or slowing down all diseases, even ones of cognition. And exercise too can also reduce inflammation. And I think what's clearly becoming the mainstay of medicine is that inflammation is supposed to underlie most diseases. So physicians are focused now on the immune system and on the behavior of genes. So hopefully that's starting to lay the foundations for what physical therapy can do as it's involved in exercise and activity. And that's when the term pathokinesiology was suggested in about 1975. McKenzie and mechanical diagnosis was becoming popular, and that was a classification system, and that was like one of the first classification systems. And it was a contrast to manual therapy because it encouraged self-treatment rather than just passive treatment. So I became involved in about the 1980s in the idea of classification when Steve Rose came to be head of the physiotherapy program at Washington University. And he wanted to work on classification or diagnosis. And he also wanted to build a curriculum around pathokinesiology. And Steve went on to develop a system that was kind of built on what McKenzie was doing, but he named it for the treatment that was to be given rather than using the terminology that McKenzie was using. Meanwhile, another group of us at Washington University began working on a classification system that was based on movements that seemed to consistently cause pain and that we could observe were not optimal anymore. And then let's just talk a minute about what happened with physician education and practice. When I first started at Washington University, the medical students spent a long time in the anatomy lab. Most conditions were identified by their pathoanatomical location. And then in the 60s and 70s, as they understood the problems differently, the emphasis became on biochemistry and pathophysiology. I know at Washington University now, the medical students spend less than a week on the anatomy of the extremities, and in some medical schools, they don't dissect the limbs at all. It's all looking at where the organs are within the cavities of the body. Meanwhile, what was also developing was the use of radiology to identify both orthopedic and neurological conditions. And there was still with musculoskeletal problems, there was this emphasis on the acute aspect of the pathoanatomical problem, and the treatment by both physical therapists was for physical agents and medications that took care of symptoms by anti-inflammatories or blocking pain. So then things began to change again in my experience because of a physician by the name of John Halasz. And he was the first one to start identifying how lifestyle affects your health. In fact, physical therapy was part of a department of preventive medicine, and they worried about exercise and they worried about diet. It was so far ahead of its time, it went out of existence before people appreciated how far it was ahead of its time. Dr. Halasz actually did what they call translational research now. He would use rats and look at what happens with exercise and changes in diet. And then they also exercised older people. He was the one that discovered the increase in mitochondria with endurance exercises. He clearly demonstrated how exercise can reduce heart disease, diabetes, blood pressure, and that even old people could get better with exercise, which is very reassuring these days for me. So what's clear now is that almost all health conditions begin early and slowly progress over time. And that exercise is like, or activity is like the most effective treatment for preventing or slowing down all diseases, even ones of cognition. And exercise too can also reduce inflammation. And I think what's clearly becoming the mainstay of medicine is that inflammation is supposed to underlie most diseases. So physicians are focused now on the immune system and on the behavior of genes. Hopefully that's starting to lay the foundations for what physical therapy can do as it's involved in exercise and activity. Moving on with what were the changes by the 1990s in physiotherapy. Manual therapy became an increasing popular form of treatment, and but now they began to include exercise as part of that treatment. The McKenzie or mechanical diagnosis and treatment method was also becoming a very popular method of intervention. And sort of led by the Australians, there was a progressive increase in recognizing the role of the nervous system as a factor in musculoskeletal disease by Paul Hodges and Gwen Jall primarily. And motor control interventions were starting to be promoted. In the United States, the educational level was changed to the clinical doctorate level. And that was because they anticipated we would have more direct access. People would come to the physio without going to a doctor first. And they wanted to make us diagnosticians who could recognize conditions that belong to the physician versus problems that we should just treat as physios. And I can tell you, though, that for 40 years, physiotherapists in the United States have labeled themselves as diagnosticians, but never actually developing diagnostic categories that would specifically direct physical therapy. So it's sort of like, where are we today? And one of the problems that we face here in the United States is that practice is highly variable, partly because it's based on treatment systems. And there's no focus on exactly what the condition is, but on the treatment system that you use. The role with the neurological patients and joint replacement patients is still a big role for the physiotherapist, though the number of days that you get to treat these patients is getting very few. In this country, physiotherapy has always been a source of income for people that ran physical therapy services. We've always made a lot of money for our owner. Now the government and insurance companies are seriously reducing reimbursement, so it's not as profitable as it used to be, and that's a problem. We're under great pressure to demonstrate that physiotherapy reduces healthcare costs, but it's a challenge, it's difficult because there's so much variability in practice. We're really not considered in this country as experts in exercise unless you've got a joint replacement, you've had surgery, or you have a definable paralysis, which is why many physiotherapists claim expertise in Pilates or yoga or some other form of exercise. And another problem that we have is that when you look at many publications, they use the term physical therapy like it's a generic form of treatment, that the patient received physical therapy without specifying exactly what that physical therapy was. And to me, that's like saying the patient took medicine without telling them what the medicine was. I can see this is going to take a lot longer than what I thought. we're almost an hour into it, aren't we? Well, that's still more than halfway. Maybe I should see if there are questions at this point about
collecting the questions. So if you want, in the meanwhile, we can still go a little bit with the presentation. And
okay.
so
Fine.
they are organizing the questions.
So here's where we are today, that actually musculoskeletal conditions, which is what I'm going to focus on, are really chronic conditions. And when you look at the statistics, they're present in 50 to 70%, 77% of Americans. We all know that recurrence is quite common. And the other thing is that treatment has been primarily symptomatic, which has led to the addiction to opioids. I don't think it's the physician's fault, because in the 1990s, pain was made the fifth vital sign, and physicians were told that people wouldn't become addicted if the pain was real. And so now we've become so focused on pain that there's a much bigger interest in understanding pain science, which has had both its good and bad aspects, like everything else. Okay, I'm going to skip over some of these other things. So I think the most important thing for us as physios is, certainly it's good to treat acute symptoms, but the thing that we have to offer is that we can help to prevent the development of a chronic condition. And I think what people need to have awareness of is that these problems actually begin early and slowly progress until symptoms develop, and then there's detectable tissue damage. When I was first working in physio, there were a lot of young stroke patients because people did not reduce high blood pressure. They didn't treat cholesterol. They didn't look at insulin levels. And all the prevention that has taken place have limited these conditions because they're doing preventive things for chronic conditions. So what I want to emphasize in the rest of this presentation is that how physiotherapists can actually treat cause rather than just treat symptoms, and that we need to change the emphasis for being recognized for what we do to patients to what we know about patients. And I think that what goes hand in hand with emphasizing what we know is for us to develop diagnostic categories that direct our treatment. As it stands now, if we only have physician diagnosis, then they are determining the problem. And what we can do is determine the problem, the cause. So I'm going to show you some examples of these little movement impairments that are associated with pain and how we can address them. So this girl she has knee pain, right knee pain, and you can see that she's going to step up a step. And if you look at the alignment of her knee, her femur's going medial to her leg. If she just straightens it out so that her femur goes directly over her foot and her leg, she doesn't get her knee pain. And rather than waiting for the knee to develop a lesion, a patellar lesion or an ACL, we know that we need to address the musculature in the hip. And the contributing factor is also the stiffness of her foot, because she doesn't have good dorsiflexion, so her knee moves more readily than her foot. Chris Powers and his colleagues have shown that 4 degrees more hip medial rotation that's demonstrated by going down a step. So you see this type of movement of her knee causes knee pain and changes tissues so that they become more osteoarthritic-like. The same movement is also a cause of hip pain, as been shown by Hayes. This young woman has knee pain. I think you can figure out which knee. This little motion of medial rotation and hyperextension is the cause of her knee pain. And if we just teach her how to not do that, that eliminates her knee pain. And you can see she too has a stiff foot and she's getting pronation. Her right medial malleolus is more prominent than her left because she typically walks with her knee rotated medially. This is an Olympic level marathonist and she had knee pain, and you can see that her right knee has more varus than her left knee and is also directed medially in relation to the leg. And the arrow is pointing out the hypertrophy of the lateral hamstrings, which have now become a lateral rotator of the tibia, and we're trying to also laterally rotate her hip. And a posterior view shows you how medially rotated the right femur is compared to the left. And then in a sitting position, again, the right tibia is pulled posteriorly laterally with respect to the femur. So when she stands on one leg, which happens a lot when you run 26 miles, she gets an increase in the varus and the medial rotation of the right femur. And when she just instruction to laterally rotate her femur by tightening her buttock muscles and aligning her knee correctly took the knee pain away. She was first seen because she was to go to China and run 10Ks around the Great Wall of China. And she was afraid she couldn't go, but with this little instruction and the change in her running and walking pattern, she was able to complete her 10Ks in China. This was a figure skater who was having left knee pain. And you can see that her left foot is turned laterally. And again, the femur is pointing a little bit medially. She's got marked prominence of the fibular head on the left side. And then the little instruction to, again, laterally rotate the femur by tightening the lateral rotators in the hip joint. She could correct that alignment. And again, just to make the point about it's these little things in everyday activities. Here she is with marked medial rotation on the left and bigger prominence of the medial malleolus on the left than on the right. The alignment on the right is good, left is bad. And then just to show how this carries over, here she is in her skating position, and her typical skating position again has this femur directed medially. You can see it's even causing hallux rigidus of her big toe. And if we get her to correct that position, then her weight line is going to come over her second toe rather than over her medial toe, and she doesn't get her knee pain. And then even going up a step, you establish a pattern and you use it in all of your daily activities. Naturally, the femur is going to go medial, corrected, the femur goes over the foot as it should be. So the message is, it's how people do their everyday activities. This is a 80-year-old woman. I remember when I thought that was old. And she has weakness in her lower extremities. And so she puts her knees together so she doesn't have to use her abductors and pushes with her hands as compared to doing it this way. So we are at the halfway point, so I could ask for questions now.
An interesting question, actually. It is probably to raise a discussion around the diagnostic process. And we have a user asking something that like saying physiotherapists must know diagnosis of doctors, so medical diagnosis, just as physicians must know diagnosis of physiotherapists, to create a sort of condition where everyone knows the diagnosis of the other. And so you have a concurrent, I'm not sure if I'm able to give you the feeling of this question, but just like, so everyone knows the diagnosis of each other, and then you create a condition where you have quite a paradox. So everyone knows the diagnostic process of the other and can also make the diagnosis of the other profession. It's quite complex to translate.
Well, I mean, first of all, I don't, if everybody knew everybody's diagnosis and could make them all, then there would be no need for different schools. I mean, and also there wouldn't be a need for different specialties. You wouldn't have neurologists and cardiologists and everything. I've known neurologists who couldn't diagnose a frozen shoulder, or they didn't recognize Parkinson's disease. I mean, orthopedic surgeons that couldn't recognize Parkinson's disease, and I've known neurologists who didn't know what a frozen shoulder was. So I think everybody has a specialty. You know what body region they should be a specialist in, but not everybody can pick up all those details. Otherwise, they wouldn't cross-refer to specialists. And my second part is what physical therapists need to know are conditions to recognize the red flag conditions that don't belong to them. There would be no need to go to medical school if I could make the same diagnosis that any physician could make. That I can't pick up the details of cancer, nor do I have access to the test that they use to make those diagnoses.
Yeah, that's actually that was actually Simone also offering his view on the question that the user made, and he agrees with you with the specificity of different professions, and of course that physicians has a role and physiotherapists has a different role, and that physicians who use labels to summarize with few lines or with few words the condition of the patient. And that's one part. He has the he also is if there is a time, he's able to show examples of things that might be useful to discuss about the process that led us that led a certain idea of how to develop a diagnostic a diagnosis in physiotherapy, which is different from just assigning a label, but it's, if my understanding of what Simone is trying to say is to through the assessment and trying to understand the cause and effect mechanism, that is something that Shirley showed really well in her presentation, we can reach a different type of diagnosis compared to physicians. He also said that so far his understanding, and correct me if I'm wrong, Simone, his understanding is that it is really in the diagnostics process, the diagnosis labels proposed in the movement system and the movement system impairments are in a way similar, and again, correct me if I'm getting it wrong, to the to labeling a condition, and in a way, but probably Simone, are you suggesting that the diagnostic labels should be longer, so including more details about the conditions, so just like wording the different elements within any specific case, instead of trying to synthesize the problem in few words, or am I understanding it wrong?
No.
Because we haven't covered.
I'm gonna bust in though, because I think that that people use labels because they're short, quick, and they convey a pattern. And I think Parkinson's disease is a good example. Parkinson's disease, it was 6 patients he reported on. It's got all kinds of manifestations, but you say Parkinson's disease, and all of those manifestations come forward in your head. And the underlying pathophysiology of it is still being uncovered. It's gone on for 100 years now. So I think that a label is a help, and then that takes you to the pattern that goes with that particular disease.
The pathokinesiological diagnosis, the possible diagnosis might be the combination of the different elements that come together to give you the idea of the final cause of the problem?
Well, I think they're pathokinesiologic. For example, the ones that we've been working on, or the neurology section's working on, it would be like fractionated movement deficit. And you can have that with multiple sclerosis, you can have that with cerebral palsy, you can have that with cerebral vascular accidents or spinal cord injury. And so, but it tells you that that patient can't isolate movement. That would be in contrast to fractionated, I'm sorry, it's like force generation deficit, where muscle weakness problem. So you can have a label, and it again speaks to a cadre of different patterns that go with it. And then if you want to tag on the additional physician's diagnosis, then it would give you other things about prognosis, multiple sclerosis being different than cerebral vascular accident, for example. I can send him the paper by sheets that spells out 3 different diagnoses for a stroke patients.
Yeah, he's willing to thank you for the presentation, and he agrees completely with you with the concepts that you have shown so far. She has 2 questions for you. The first one is, if you believe that something is still missing in the physiotherapy science or an understanding of phenomenon to achieve or to be able to define a precise set of diagnoses? And or why do you think we are not able to achieve, and Melania, correct me if I'm wrong, like a consensus on a set of diagnoses? That's the first question.
If I can answer that effectively, I get a Nobel Prize.
Se potesse essere in grado di risponderti in modo efficace a questa, le darebbero un premio Nobel.
Well, let me just take, I think we started working at trying to get something in place with diagnosis in 2006. And we're still working at it. I think it's very hard when people have invested interest already. And I think was trying to make the point that we've been so focused on treatment, we haven't looked at cause. We haven't looked at putting labels on things. And it's just going to be difficult to have people kind of reorient their thinking to putting a label on a condition versus just thinking about how to treat it. I don't think there's much recognition of movement as a cause of problems. I think there's still like, here's the tissue that's bad, and I need to do something about that tissue.
So she really thinks that we need probably to define a set of alliances between different nations to work on the diagnostic processes, because otherwise the risk that we have is that without a precise idea of diagnostic processes and diagnosis, we will end up losing competencies and disappearing as professionals, because other people will slowly taking pieces of our job or of our competencies.
Well, you know, in some ways you hit on why I'm so concerned now, because I think that other people are taking all kinds of pieces, and I don't think we've made a good case for how complicated movement is. And so exercise programs are very big in the United States, particularly endurance, high intensity exercise, and that's creating as many problems as no exercise. So I think it's already divided up. Let me just put this one thing out there that's a little disappointing for somebody of my vintage, that the psychiatry group started in 1952 to put labels together, and they published their first book, DSM, Diagnosis and Statistical Manual of Psychiatric Disorders. And it wasn't until the fifth edition, 1982, that they started into general use. People were using them, but there wasn't as good an acceptance as there is now. So I think it's going to be a long, drawn out process. What I'm worried about is getting it started. And yes, it would be ideal, but we're going to have a hard time just within one country to get anything consolidated.
Go through and
yeah, let's just go. Let's just skip to make the major point.
Yep.
I mean, then the major point, when I was trying to show with the knees, it's the way you do your everyday activities, repeated movements and sustained alignment that make your back move too readily. Skipping over all of the other wonderful details, a study that was done to show that if you have people keep their back still during all of their basic activities is an effective, probably the most effective treatment for low back pain. And there are 2 points to this, so that people were classified according to the movement that causes their pain. And these were all people with chronic low back pain. And one group was given specific exercises and the other one was given general exercises. But both groups were taught to keep their spine neutral while they practiced all of their functional activities, like rolling, walking, sit to stand, bending over. They were all taught, keep your spine still. People were seen in physiotherapy 1 time a week for 6 weeks, and every week their program was carefully progressed. The outcome measure was a modified Oswestry score, which is, do you have pain during certain activities? And these are the outcomes. At the initial visit, their score on the Oswestry was at 20. 20%. After treatment, it was at 15%. And without treatment, it went down to 10% 6 months later. There was a little upswing at the end of 1 year. And what was also important about this particular study is that the investigators monitored whether they adhered to keeping their spine still during their activities. It was called performance training, or whether they adhered to exercise. So what you see is that people adhered much better to performance training as compared to exercise, which they stopped doing almost, they fell off dramatically right away, and certainly by the end of 1 year. Linda has done a follow-up study in which patients were given just stretching and strengthening, no keep your spine still, and the others were taken through a real motor learning version of, they called it motor skill training. Their activity that caused a pain, they figured out what movement they were doing that caused the pain and how to correct it. It was the same format, 6 treatments over 6 weeks, and then, but continue to monitor them for 1 year. And the outcome was both groups got better, but the people with the motor skill training got significantly better, a whole lot better and a whole lot faster. And the Oswestry scores were twice as bad in this group as they were in the second group as there were in the first group. I think it says two things. That changing the way people do their everyday activities is the most effective treatment that we can provide, and it's one that people will do. And the second big point is, if it's changing the way they do their activities, that must have been the problem in the first place. So it's that it initiates the problem, and it's the way what has to be fixed to have the most effective treatment for it. And I think this is the way that we can make a point that we're treating cause rather than symptoms. And the movement causing the problem was all connected with the diagnosis that they make for physical therapy. So just let me say this, I'm sorry I had too much planned for the lecture, but if people want to send me questions, if you all want to send them to me, I'll be happy to try to answer them. I don't think we should carry out this too long, but if I can return them by email or something.
Okay, so we have a plan for a future webinar with a question and answer. Carlo wants just to conclude this webinar with one of the really recurring questions that we always get. So here we have a question about, in light of the current evidence on the neuroscientific evidence about the interaction between how you communicate with the patient and the effects that you might get on, for example, on kinesiophobia, instructing the patient about, well, avoid this movement because it is going to cause pain. What do you think about the possible problem of causing fear avoidance, for example, or using nocebo terms?
It's always been the way that I've dealt with patients is that I don't think you teach them to avoid a certain movement. I think you show them how they move without pain. And so it's always been for me, having them start off in the most pain-free position they can be in, and show them how they can move and not get the pain. And usually if you correct the movement, the pain goes down substantially. There's, I think people have a legitimate right to worry about some movements, particularly the way they're performing them. And that's part of this. Oh, I'm carrying on and on. You need to go. A specific example is, for example, if people have pain with forward bending, what we've shown is that in some ways they have an earlier, greater amount of lumbar flexion during forward bending. If we show them how to flex their hips and avoid the motion of their back, then they don't get their symptoms. And Linda's they have a paper published showing just that. Yeah, I hope that's really clear. When you identify the movement that causes pain, you don't say, don't do that movement. You show them how to move correctly so they don't have pain with that particular movement.
okay, so Carlo was saying hello to everyone, saying that we will schedule another webinar in the future, answering all the questions. And thanks to everyone for the participation, and especially to Simone, Gianluca, and Melania that are still here with us. And yeah, Shirley ha detto è stato un piacere conoscervi e conoscere tutti. Quindi a presto a tutti a questo punto. See you soon.
Se volete aggiungere qualcosa fate pure.
Yeah,
non vi mando via, più che altro avevo paura a tenervi qui, ecco, che era un'ora e mezza e ci siamo così.
Okay.
Okay, thank you all very much. Nice to see you again.
Thank you. Nice to see you.
Sì.
Have a good day. Bye bye.
Bye bye.
Thank you,
Bye bye.
Grazie, arrivederci.
Ciao ragazzi. Ciao ciao.